Good afternoon. Absolutely delighted to be here today. By way of introduction, my name is Rachel Stockton. I work here at the Surgical Data Science Collective, and we're absolutely delighted to welcome Dr. Matthew Pease for October's Data Science Roundtable. A quick bit of housekeeping. If there's any questions, please feel free to raise a hand or to pop the questions in the comments. This is a new platform, so forgive me if I say comments and there's not actually somewhere to write comments. I'm just looking at my screen. I'm sure there is, but yeah, please feel free to do that. And if you've got any questions, please just ask them as we go. Don't wait until the very end. So with no further ado, I'd like to take a moment to introduce our guest. Dr. Matthew Pease will be speaking today on AI and the neurotrauma ICU. Matthew is a neurosurgeon who specializes in care for patients with cancer and trauma. He joined the Department of Neurological Surgery at Indiana University School of Medicine in August 2023. Dr. Pease graduated with high distinction in economics from Duke University, where he developed models to better understand how the brain is structured to make economic decisions. After graduating, he completed medical school at the University of Southern California and trained in clinical neurosurgery at the University of Pittsburgh Medical Center. There, Dr. Pease developed an interest in better understanding how to predict outcomes for trauma patients, communicate expected outcomes to families, and better prevent complications during the course of recovery. After residency, Dr. Pease completed a fellowship in neurosurgical oncology at Memorial Sloan Kettering Cancer Center, the first institution in the US devoted solely to treating cancer. Dr. Pease specializes in using functional mapping and minimally invasive tools to minimize the impact of surgery on the brain, allowing for faster recovery. As a fellowship-trained data scientist, he is pushing cancer care forward through developing new AI-based tools to help diagnose and treat cancer more effectively. Dr. Pease's work has been published in numerous peer-reviewed journals, including the Proceedings of the National Academy of Sciences, Neurology, Annals of Neurology, Radiology, Neuro-Oncology, Epilepsy, and Neurosurgery. Dr. Pease, we're so thrilled to have you today. Over to you.
Thank you so much. Can everyone hear me okay?
Yep.
Perfect. So thank you for the very kind introduction. My name is Matthew Pease. I'm a neurosurgeon at Indiana University. My interest is in predominantly trying to figure out how to use AI to better prognosticate or phenotype patients that we have within neurosurgery, and then can we use this information to help guide clinical trials. Oftentimes, and this is some of the things I'm going to talk about today, disease categories are too broad. We say that this is this type of cancer, this type of trauma, this type of injury, but really we find on further understanding or harnessing all of the data that's located in the electronic medical record that it's really several subtypes of disease. And this is what we talk about when we talk about phenotyping. And a one-size-fits-all category for treating these diseases isn't always the best answer. And we can use different approaches depending on the patient or other things that our models allow us to really understand better to help guide therapies. Once we've built these models, once we've identified these phenotypes, I then specialize in trying to bring them into the clinical space so that we can actually use them to help our patients. I've been doing data science or AI research for almost a decade now. And the one thing that I constantly find is that we have trouble getting our findings and what we're doing to try to help people into the clinical space. I was at McKay, which is a large international computer vision conference about 2 weeks ago, and it's very impressive, all these models and innovative approaches for how to build better computer vision models to improve predictive performance of various things. But what's really interesting is that people spend so much time figuring out how to make your model work and get your AUC 1 or 2 points better, but there's such a large gap between what we can actually get into the clinical space and what we can actually use to help human beings, that's the bigger problem. It doesn't matter if your model is marginally better than the model before it. It matters, have we gotten your model or your product or your new concept into the clinical space to actually start helping people. So today I'm going to talk about a little bit of the work that I've done within the neurotrauma space, talk a little bit about some of the models we're using, but also splice in a decent amount of the clinical understanding of, are we asking the right questions? Because it's not just, can we technically build these models, it's, are we asking the right questions to actually help our patients? I don't have any significant financial disclosures. I'm in my second year of practice and just have a couple of early investigator grants. Here is an outline for the topic for what I'm going to be talking about today. The first is why focus on neurotrauma. I want to try to make the point that neurotrauma is a big data problem. How can we develop phenotypes of TBI? We have a problem with how we categorize and treat TBI, and that's led to large-scale failures within neurotrauma clinical trials. Can we build new models for phenotyping this disease and try to move more from a reactive to a predictive medicine approach? And then lastly, if I have a little bit of time, I'm going to talk about what is the actual outcome we should measure, because this is a fundamentally interesting and ethical question, especially within neurotrauma. What are we trying to predict isn't always a very easy question to answer. So why focus on neurotrauma? So the facts are relatively easy to justify. It's the leading cause of death and disability, both in the United States and worldwide for those under 40. It accounts for 1/3 of all of the traumatic deaths. The numbers are staggering. In North America, we have about 5 million traumatic brain injuries every single year. And trauma accounts for more years of lost working years and life expectancy than any other disease. Accidental deaths are the 5th leading cause of death in the United States. But when you look at trauma is a primary bimodal distribution of its disease. You have a lot of elderly, as the United States is aging and a lot of Western societies are aging, who fall and have injuries, but it's also a young person's disease. A lot of people in their late teens, 20s and 30s tend to be the people who perform slightly riskier behaviors, drive their cars a little bit faster, have underdeveloped frontal lobes, and don't make as good of decisions, and end up getting into trauma. And that's in comparison to most other diseases like cancer, heart disease, that are affecting people towards the end of their productive years. People have already lived 2/3 or 3/4 of their life by the time they get this disease, and although it does shorten lifespan, the consequences of shortening your lifespan when you're in your 70s is very different than when you're in your 20s. Not that all life is not valuable, of course. And the second, it's not just mortality, it's the morbidity and disability associated with the disease that's exceptional. This is looking at patients who had what's traditionally called a mild traumatic brain injury. These are all people who were working before their injury. This is a large cohort, prospectively collected, of almost 3,000 people. And what you can see, these are people who went home from the emergency room that day. They had an injury at football practice, got in a car accident at a relatively slow speed. We're not talking about major injuries that are putting people into a coma or needing intensive neurosurgical procedures. These are the type of injuries that you go home that day and everyone says you look like you're doing fine. And what we find is that 50% of the people are not working at 2 weeks. Even when you go out to 3 months, a full 25% of people who were working beforehand are not working afterwards. And those numbers stay in roughly the 75 to 80% return to work rate, with about 20% of people not returning to work at 1 year. It's very disabling if you're 25 years old and have to take an entire year out of work because you're having symptoms and sequelae from your quote unquote mild traumatic brain injury. And it's not just that people are not returning to work. About 20 to 25% of these people, even at 1 year, are reporting that their annual income has declined. Even if they are getting back to work, they're not working full time or doing the same quality of job that they were doing before. There's no such thing as a mild injury. All of these injuries have significant impact on our patients and their quality of life. I'm going to talk about just a couple of basics here about traumatic brain injury. One of the major scales that we use is called the Glasgow Coma Scale. This has been used for about 70 years now. It assigns various points. It's an ordinal scale from 3 to 15, 15 being a normal person, 3 being a person who has no obvious signs of brain function. when tested by people familiar with neurological exams. We divide it into 3 different categories with eye response, verbal response, and motor, which is how you're moving your arms and your legs. The key thing to know, the canonical way of classifying traumatic brain injury is into mild, moderate, and severe. This is based on the GCS scale, with GCS 3 of 8 being comatose patients who are classified as having a severe traumatic brain injury. This has a very high rate of mortality. At 6 months, approximately 40%, depending on what patient series you look at, a little bit more, a little bit less. Mild TBI is far and away the most common. These are patients with GCS of 13 to 15. Maybe they're a little bit confused, but then return to baseline, versus people who have no active external signs on a brief neurological exam to suggest that they have focal deficits. The other thing we do, I don't know why Glasgow is the originator of all the scales in trauma, but the Glasgow Outcome Scale is the major scale that we use to look at how people are actually doing. This is also an ordinal scale. The expanded version is most commonly used, but even the original map to each other, it's an ordinal scale that goes up to 8. The basic way to think about it is at 5 to 8 is considered a favorable outcome. These are patients who are able to return home. They're able to live and accomplish some tasks. And it ranges from people who are working in a grocery store in a protected environment all the way to people who are entirely asymptomatic and have no problems further. So next, I want to focus on the idea that neurotrauma is a big data problem. It's a big data problem for several reasons. The electronic medical record has an astronomical amount of data in it. The Royal Bank of Canada, their consulting arm, which is a very, very large consulting group, estimates that 1/3 of all data is located in the electronic health record. In our clinical day-to-day workings, we have nurses who collect hourly vitals, neurological exams. We draw hundreds of labs on patients every single day. We get a hugely intensive amount of imaging, which is very, very data heavy. These are terabytes and even larger amounts of data per patient. And a lot of the data, depending on what source you're looking at, 50 to 75% of data is focused on the brain. MRI is more data intensive. And we get serial imaging and track how the brain progresses over time. When we look at radiology departments, the neuroradiology is often the largest. And so this is a huge amount of data that we all have at our fingertips. I'm specifically interested in the acute care in neurotrauma and traumatic brain injury. One of the acronyms you're going to see throughout this is TBI. That stands for traumatic brain injury, for people who are unfamiliar with that. And in the ICU is when we have the most intensive data collection. And in neurotrauma, we collect a whole range of data, including data from within the brain itself. Most patients who go to a neurotrauma ICU have higher grades of traumatic brain injury. They're often in a coma. And in these patients, we put monitors actually into their brain to look at a whole host of different factors, including what are the pressures inside of their brain. As we get bad injuries, our brain swells. Our brain, unlike when your ankle swells, your brain can't just get bigger and bigger. We have a skull in the way. That can compress the brain and cause it to restrict its blood flow. We get brain tissue oxygenation. And we can put in electrodes that record the actual electrical activity from the brain. We often do this on the scalp with something called an EEG, which is the other most intensive data source in medicine, EEG and imaging. And it's not just these simple reports that we have of this is what the imaging looks like. We actually have waveform data. And we as human beings are very, very bad at looking at the waveform of an ICP monitor and figuring out how does the waveform, is that predicting future problems? But computers and with advanced modeling, we're able to look at this and look into the future of what waveforms and subtle changes, not just the actual number of what the pressure is, predict some of the future. These are just some of the guidelines for the management of severe traumatic brain injury, recommending the use of ICP monitoring, which is one of the intensive sources of data. And for a long time, we had the other problem of we didn't have systematic ways to track traumatic brain injury. Traumatic brain injury, all of these patients initially look like they're struggling. They're often in a coma, not responding externally, and it takes a while for the brain to quote unquote reboot. And Track TBI was the first group that really came out and said, we're going to systematically study long-term outcomes. This was such a large grant that required lobbying in Congress to get approval, and tens of millions of dollars, including Track, Center, and now Enigma, which is another large group. And these groups have done an excellent job of taking focused cohorts of patients, collecting large amounts of data about these people, and then systematically following them for years at a time. Track has outcomes up to 5 years for their patients. Sorry, that was green tea if it was awkwardly yellow. But this amount of data that they're collecting is allowing us to start to understand what is all the imaging and other information that we're collecting for our patients. How does this correlate with the outcomes at 6 months to a year? Track TBI followed about 3,000 patients. Center TBI is doing 10,000. Enigma doesn't have as much rigorous data collection processes, but they similarly have thousands of patients. And what at the end this means is we have this high intensity data, especially in the ICU. We have multimodal data with multiple different avenues of data, including intensive data being acquired from within the brain itself, that we need to figure out a way of how can we bring this all together to understand what's actually going on in the brain, to understand how are the patients going to do, and what can we do to help treat the patients better. And this brings us back to the idea of a TBI phenotype. This is the current standard that we use, the classification of traumatic brain injury, all the way over to the side here, where it says mild, moderate, and severe. The traditional clinical way we do it is using the Glasgow Coma Scale, which is mild is 13 to 15, moderate is 9 to 12, severe is 3 to 8. There probably isn't a corollary in medicine of another disease on a broad scale that we call mild, moderate, and severe. Imagine if we did this for breast cancer. Imagine if you told your aunt who, just got breast cancer and is doing well, sounds like you had a mild case of breast cancer there. I don't think you'd be invited to the next holiday gathering based on that. We have very different and nuanced ways of how we describe breast cancer, heart disease, bone fractures that are very, very different than mild, moderate, and severe. The GCS scale is also a heavily flawed scale. It's very, very useful. But what you can see here, this is a hard graph to see because it superimposes multiple graphs on top of each other. But basically, people at one spectrum of the GCS are highly, highly disabled. And then once you get to the middle portion of the spectrum, in a relatively large amount, from roughly 3 to 12, overall mortality doesn't change that much until you get to a very favorable GCS of roughly 14 or 15. And what this has done is a lot of our guidelines with severe traumatic injury, or these patients who are in a coma, recommend that we put in intracranial monitors or do things based on the patient's GCS. This is a very heterogeneous disease. This is not a one-size-fits-all. And what this has led to is a whole bunch of high-profile clinical trials that nearly universally end up being negative. When I say negative, what I mean is the results don't end up showing statistical significance. Part of this is because of the clinical trial design, but some of this certainly is because that we're trying to apply treatments for patients who don't need them. Some of the patients that we put our monitors in don't need it, whereas others continue to have problems. This is looking at an ICP monitoring strategy where we actually did invasive procedures in patients. This trial ended up being negative and not showing a benefit. And very, very interestingly, despite this trial being negative, guidelines for major societies all universally recommend placing these monitors because we have such good observational data to support that they work. This is a trial looking at doing an actual surgery and taking off roughly a third of the skull to allow the brain to have more room to swell, showing that this doesn't improve your functional outcomes. Again, this is not a one-size-fits-all. We can't flip a coin and decide who are we going to do surgery on and who are we not going to do surgery on, because the answer is much more nuanced than this. Recently, we've been adding blood-based biomarkers, which is another avenue. And the real problem is that TBI is a heterogeneous disease. This is MRIs from 3 separate patients. All of these patients can have similar exams with disabling neurological exams and sequelae of their disease, but their imaging looks dramatically different. There's a fundamental gap in how we're understanding these patients. The imaging all looks very, very different, and these patients can all have the same exam. Here's an example of a patient with an epidural, a little bit of blood right here, a broader base subdural, and then some smaller little spots in the brain. And all of these patients outwardly can look different, but the consequences to their brain and what's going on underneath can be very, very different. This has led to a new classification system that within the past 6 months has come out, where we're trying to get rid of the mild, moderate, and severe, and we're just going to describe what the patient looks like. What are their blood-based biomarkers? What does their imaging look like? What does their clinical story look like? But this is a problem when we're using broad categories of patterns of blood like epidural hematoma or subdural hematoma, instead of using a much more nuanced approach in developing phenotypes. And so what is some of the work that has been done? How are we trying to move from reactive to predictive medicine with the development of phenotypes? So this is some of the early work out of Track TBI, and they did something relatively similar or simple. They looked at all of the different, these are the 6 locations where you can bleed within your cranium, or the types of intracranial blood. And the Track TBI cohort just looked at a binary 1 or 0. Do you have blood in this location? Not is it a big amount of blood or a small amount of blood, but just is this present? And then they looked at how often are these different blood patterns characterized together. It's very common, for example, to have a contusion and a subarachnoid hemorrhage, whereas another cluster has IVH and petechial hemorrhage. And they realized that there's really 2 or 3 patterns on gross description of the blood that they can find, and that these patterns are dramatically more predictive of long-term outcomes than looking at each individual location of blood. But this is also heavily flawed. This is not looking at a massive amount of the information that's actually there. It's not quantifying how large the amount of blood is. We really don't have good tools to understand how are our patients going to do when we actually look at the brain, aside from using human expertise and human interpretation. Several years ago, I did the first CT-based outcome study in traumatic brain injury using the Track cohort and a cohort within my institution at UPMC. The UPMC data goes back about 25 years. We're looking at all severe traumatic brain injury patients. We only had 220 patients from Track. The reason it's a much smaller number, I told you Track originally has 3,000, is about 10% of patients are severe traumatic brain injury, and this is the group that we're focusing on. The first thing we did is we built some relatively simple models, including a neural network and an LDA model. We compared it to IMPACT, which is a logistic regression model that's been validated on tens of thousands of patients, and not surprisingly within our own data set using relatively the same broad clinical data, we were able to show that our models work better than standard logistic regression. We then combined that with a deep neural network learning of our CT head scans themselves. We used a customized convolutional neural network to accommodate the full slice volume from a CT scan. And we used an AlexNet backbone. This is something we did several years ago. That's why we're using AlexNet. We used ensemble stacking to put them together. And then we tried to see how does our imaging actually do, and then how does it work when we validated it with Track. Within our own institution, we noticed a significant improvement compared to IMPACT. The convolutional neural network imaging model had an improvement, although it did not reach statistical significance in this particular test. There are 2 ways that we could do p-value testing. Track required us in our actual publication from this to do a more rigorous and putative multiple comparisons. When we used a bootstrapping approach for finding p-values, this value ended up being significant, but ultimately they control the data, so we do what they want them to do. And then when we moved over to comparing with our Track data, how our model built on one institution did. There ended up being some data shift. I will show that the imaging model was just as effective as the impact model at predicting mortality, which is a huge value add. We know, and I'll talk about this later, that people are very bad at predicting these models. An automated imaging model is very quick and easy to deploy, whereas impact has a lot of tedious data requirement elements, so it does provide a value add. And we've subsequently improved these models, including working with TRAC and other data sources to augment the number of patients that we have. This is just the actual rock curves and what they look like. One of the things I went through is I went through a group of attendings. These are board certified neurosurgeons, and asked them, how do you think these patients are going to do? And as you can see here, all of them did worse than the models that we were testing. There's one example of a guy who did very, very well in unfavorable predictions, horrible in mortality. It's just kind of a fluke of how he described the data. And one of the very, very interesting things, and this is very important, is predicting mortality within traumatic brain injury is a very big deal. If you predict that someone's going to die, these patients are in a coma. They are dependent on aggressive medical interventions to be able to survive. If you predict someone's not going to survive, and then people act on that, that often means withdrawing care, taking out the breathing tube, stop performing intensive and expensive surgical interventions that are necessary for survival. So one of the innovations we did within this field is that we brought our specificity down to up to 100%. What that means is our model is attuned never to make a mistake. And then we really looked at what's our sensitivity for finding mortality. And we still had reasonably good sensitivity. It was about 56% under these very stringent conditions. And what this means is very clinically useful is we don't want to be predicting someone's going to die, then we act on that information and withdraw life-sustaining therapies because that's a mortality-inducing event. We'd rather have a more stringent model that's not as doesn't predict mortality as often, but is quite certain when it does make these predictions. This is just the rock curve for the TRAC validation. As you can see, all of the models roughly had similar overall predictions. But that's only including one type of data. That's just looking at the brain and some very rough clinical data. There's massive amounts of other data that we talked about that's available to help with these patients. This is in the same cohort of patients at UPMC. This is using a Bayesian trajectory modeling technique. What this is doing is this is just looking at the intracranial pressures. Again, that's where we put that monitor actually inside of the brain and started to measure what are the pressures. And what we found is there's 6 different phenotypes or courses or trajectories of ICPs. 20 is often considered the threshold of what is considered really elevated. Most of these, except for 2 of the groups, almost all of the patients look like they have ICPs lower than 20. That doesn't mean they're under 20 on their own. Oftentimes we are using aggressive maneuvers, including doing surgery or giving very, very powerful medicines to try to keep the overall average of ICPs down. But what we find is there's several different categories of patients. Several of the patients have lower ICPs that just get higher over time. Some of them have a lot of variability. Those patients can be very challenging to treat because if you give them a very aggressive medicine and then they swing to the other side of pressure, that's a very difficult thing to deal with. And what you can see is you see different rates of needing surgery or this decompressive hemicraniectomy where we remove a majority of the bone based on which of these trajectories you have. This is just showing some of the variability between these patients. As you can see, some of the patients end up being in the small little band. Some of the groups have much more outliers or larger variance. Sorry, my phone was buzzing at me. And that these trajectories have different long-term outcomes. This is looking at the GOS, whether or not you're at a favorable 4 or 5 versus 1 to 3. And these trajectories have very different groups overall. And some of the surprising thing is the group 6, which had very, very high ICPs and a lot of variability and had high rates of needing surgery, is a group that we were worried might not end up doing well. And a lot of these patients ended up having very, very good outcomes. So there's something that's happening that's tilting people into these different categories, and something fundamentally different about how they respond to treatments. All of these patients were given the same treatment categories of, escalating therapies with medicines and surgery if medicines become intractable, and this is what this ends up leading to different outcomes. But it's not just intracranial pressure monitoring. We can also measure the brain tissue oxygenation, which is how much oxygen is actually coming to your brain, and can we use this to alter our management and further guide the management that we're doing. But our approaches to this are very, very simplistic. This is Boost 3, which is an ongoing clinical trial. And instead of looking at how do these values change over time, and can we have more instructive tools to build PbO2 and ICP and imaging all together, we have a little chart, and it's check this off. Is this number greater than this? Is that number greater than that? And this is the problem with these simplistic approaches we're using to treating these patients. Once we start to incorporate multimodal data, our ability to predict outcomes gets better, and this outcome improves over time. This is another group that just had repetitive logistic regression models. Every single 6 hours, they were rerunning the logistic regression model with doing the previous prediction is one of the input variables. And they show that over time, as you get out to a couple of days, you have drastic improvement in your ability to predict long-term outcomes. And these are relatively simple models that we're using, because we just don't right now, hopefully this is something we're going to improve, have complex models that incorporate a large amount of data and information into them. And one of the problems that we often run into is, even within imaging, we don't have large-scale tools to describe imaging phenotypes, or even the different components of the imaging on sort of a mass level. It's very manually intensive to segment out or describe imaging with radiology. You can use natural language processing or language models to try to describe some of this imaging, but it lacks the same type of accuracy, and the heterogeneity when you look at radiology reports just isn't quite as accurate as what we need to do. And so we launched at Mackay last couple weeks ago, and we're going to do this again hopefully next year, a challenge to try to segment brain injuries and segment blood volumes. This is a really big problem, because some people with brain injuries don't have fluid blood on their head that are easy to see, so some scans are negative. It's not just a simple Dice coefficient. You can see there's very different patterns of blood. You have a small little contusion by the skull here, a small contusion, blood within the intraventricular space, or over here in the sylvian fissure. It ends up being a much more challenging segmenting task than most of the other cranial segmenting tasks that I've been a part of and seen. We ended up, we had a huge problem in figuring out how do we even score this. It's not a simple thing like looking at a Dice coefficient and saying how often are your voxels correct, because some patients had a negative CT scan. And so we try to come up with various maneuvers that were putative towards incorrectly calling lesions that shouldn't be there in what are otherwise normal brains, but then fully capture the idea that if you can get 95% of a lesion correct, that is, and identify the lesion, that you deserve some type of reward for doing extra with that. I thought I had put the paper in there. Oh, no, I do have the paper in here. This is one of my favorite paper names. One of our collaborators had a paper called Metrics Reloaded, obviously after the very famous Matrix movies. And we came up with a whole variety of approaches trying to really quantify how do you actually capture segmenting mass for this. We had about 6 or 7 different groups participated in this challenge. We had a lot of very interesting approaches, people building multiple models and then combining them, or using various approaches to filter out one group's just filtered out very small lesions because they realized it was very hard to find them, and you're better off just focusing on slightly bigger lesions. They ended up slightly taking advantage of how we ended up scoring and ended up doing better than they probably would have for the number of lesions that they were finding. And it's not just identifying where are lesions, but also looking within traumatic brain injury. How do you identify other important clinical variables? Kind of taking a little bit of a turn to another area of research I'm interested in is looking at post-traumatic epilepsy. Post-traumatic epilepsy accounts for about 20% of epilepsy overall. Epilepsy is a major disease. Drug-resistant epilepsy has a higher mortality over 10 years than breast cancer does. It's very common in traumatic brain injury patients. About a third of them will go on to develop this. We don't have tools to identify very well who are the patients who are likely to develop epilepsy. This is very important because epilepsy is a progressive process. It's not just you hit your head, you have a seizure, you go on having seizures. It's you hit your head, you have a neuroinflammatory process that builds up over time. And the average onset of seizures is about 7 months after initial injury, but can happen even decades later. And this is an increased risk that continues for the rest of the life for patients with traumatic brain injury. If we can identify patients who have post-traumatic or at high risk for post-traumatic epilepsy, we can potentially give them medicines that abort some of these pro-epileptic pathways and alter the course of their disease. Post-traumatic epilepsy is a major form of what's called secondary injury and traumatic brain injury. We can't undo the injury that you have. If you're in a car accident, I can't undo your accident, but what I can do is stop secondary forms of injury. And if you're trying to recover from a traumatic brain injury, it doesn't help to have your brain electrocuted again and again and again as you're recovering. This is looking at a large cohort. 20 to 30 patients is a very large cohort for these type of intensive EEG studies. We had an epileptologist who went through and visually looked at EEGs taken within the first 3 days of trauma. They were unable to find anything within their analysis that predicted long-term risk of epilepsy. And so we did fast Fourier transformation and developed a series of quantitative EEG markers, and we were able to find significant differences in the spectral power and the shape of the waves. I don't know if anyone has seen EEGs before, but it's just a waveform, basically how sharp the waveform is and how rhythmically you're having these waves. That it helps predict long-term whether or not you're going to have post-traumatic epilepsy, and this is not equal across all the different spectral powers, and this is true whether or not you've had surgery or not. Obviously, if you don't have a skull there from a decompressive craniectomy, the power of the electrical discharge is going to be larger because you don't have as much of a barrier. We can use these tools with clinical inputs to help understand our patients who are at high risk, but that's not the only way, and we're adding more sophisticated tools that capture the true variability in this data. We developed something called the mean absolute deviation. What is really interesting about this is this captures both the clinical and quantitative approach we're using within caring for our patients. Pre-epileptic activity is often sharp little spikes with normal activity around it. These are how seizure and epileptic zones get started. So we looked at variability for individual electrodes and how that compared to the average of the electrodes for the whole. And we found that patients who have focal bursts or large variability across the spectrum of their brain are more likely to develop epilepsy. This is something that persists over time. Here you can see that patients with PTE compared to those without have much higher mean absolute deviation. And we can use the simple classifier to do a reasonable job. This is just a support vector machine, just looking at the mean absolute deviation to try to predict who's going to go on to develop post-traumatic epilepsy months to years later. I was going to pause here to see if anyone had any questions. I didn't know if there's anything in the comments. And then I was going to talk my last couple minutes. I think I was supposed to end in about 3 or 4 minutes about what is the outcome we actually want to measure, which is kind of a change in the conversation to a slightly more ethical question. Does anyone have any questions about what we've talked about so far? Okay. So next I was going to talk about withdrawal of life-sustaining therapies. So intrinsic in our models is we're trying to predict something. We're trying to predict how are our patients going to do. Are they going to be alive? Are they going to return to functioning at their baseline? But that depends on human actions. What do we do and how do we allow our patients to get there? With severe traumatic brain injury patients, these are all patients who are in a coma. They're all intubated. They need breathing support. They need aggressive cardiovascular support to keep these people alive. We know that the longer we follow these people, they end up doing surprisingly well. At 2 years' time, 95% of people who are in a comatose state at presentation are either dead or move on to having independent living. Paradoxically, those are the two outcomes most Americans and Western people are okay with. What they're not okay with is living in a highly disabled state, which is much less likely. Our patients, the longer we follow them out, end up doing very, very well, but we have this problem that these patients are in a comatose state. They're not responsive. They look like they're very sick. And what happens is, even at high-end academic medical centers, is providers say, we don't think these patients are going to do well. They haven't started to come around. They haven't started to emerge from their coma. And then, based on perceived poor neurological prognosis, families decide to withdraw care and not pursue aggressive cares. And this is a major source of mortality across the neurosurgical and neurosciences spectrum. Here are the leading causes of death in the United States. You can see heart disease, unintentional injuries, which is trauma, and stroke. Heart disease, a significant cause of death for heart disease is patients who have anoxic brain injury. Their heart doesn't pump blood to their brain dies. And so these patients show up like traumatic brain injuries in a coma. Patients with stroke obviously have disabling neurological problems. And for a lot of these major diseases, it's actually the neurological prognostication that is the thing that drives decisions to withdraw care. This is looking at patients who died within a hospital and looks at patients who had withdrawal of care compared to patients who died for other causes. You can see at large teaching centers where the majority of deaths in the US actually happen. About 30% of patients who had care withdrawn had it for perceived poor neurological prognosis. The majority of patients ended up having withdrawal of care. Nearly 80% of patients had withdrawal of care compared to those that went on, maybe 20% of patients that went on to have brain death or death due to cardiovascular or respiratory failure. And this is a problem in traumatic brain injury because almost 3/4 of deaths are due to withdrawal of care. The majority of this happens very early. These are when the patients look the worst, but we are the most inaccurate at trying to understand how these patients are doing. A group in Canada looked and said, well, what matters more? There's a large variance in hospitals between how often they withdraw care. What matters more? The hospital you go to and how they withdraw care, or whether or not you needed surgery, your individual patient characteristics, or everything like that. And they found that your withdrawal of care, the hospital you actually go to, matters way more for whether or not you're going to survive your injury than individual patient characteristics. And this has been shown across several neurological diseases. This is the Center TBI experience that's looking at Europe. About 86% of deaths were due to withdrawal of life-sustaining therapies, with half of them occurring very early. So I went through and I systematically explored, fundamental to this idea that we're withdrawing care is that we can accurately prognosticate how patients are going to do. Withdrawing care is not necessarily a bad thing if we can have a crystal ball and see into the future. But when we have our, board-certified physicians look through and try to predict how patients are going to do, looking at both mortality and unfavorable outcomes, that about 35% of the patients ended up dying, and about 30% had favorable outcomes at 6 months, which is the outcome we're looking at. And what you can see here is when physicians try to predict how their actual patients are going to do, they don't really do that much better or any different than a properly weighted die would do. Which is a big problem. we tried to look, are there certain things that can predict whether or not the actual or clinical variables, whether or not the accuracy is going to be high, such as your age or neurological exam, and none of them had very high predictors. We're not very good as physicians or accurate physicians, even when you get to extremes of age groups. And the longer we follow these patients, the better they do. This is looking at patients who show up comatose to the emergency room, and how many of them, if you wait a couple months after their initial injury, end up starting following commands and have high rates of regaining consciousness and going back to independent living. And I kept talking earlier about the idea that a lot of this withdrawal, almost half of it occurs within the 72 hours. We went back and looked from a backwards end. What happens if we look at when patients emerge from their coma after a severe traumatic brain injury? And we looked at patients who had a favorable outcomes. These are only patients who ended up going on to have independent living. And we found that it was nearly 9 days until patients who had favorable outcomes went on to emerge from their coma. It's a big problem if we're withdrawing care within the first 72 hours. And this is a terminal event. If you have care withdrawn, there's no way that you're going to be able to improve and go on to survive. And it is undoubtedly that we as physicians are withdrawing care too early, and some of our patients are dying who would otherwise go on to have good functional outcomes based on how aggressive in medicine we are at withdrawing care. Now, this brings us back to our models of what are we trying to predict? If we use mortality as our outcome measure, are we really predicting the overall rate of mortality in a true ground truth sample? Or are we predicting the subset of patients that physicians think will not do well? And that's a big problem within all of the neurotrauma research. It doesn't matter how fancy or good of a model you have. The ground truth is very hard to come by, and it's not something I'm sure we really, really know within the neurotrauma population. I wanted to thank everyone for coming to my talk, and this is my email and my phone number, and I'm happy to answer any questions should anyone have any.
Okay, folks, I know it takes a moment to come off mute, but if anyone wants to raise their hand to ask a question, then please feel free. Okay, I've actually got a question, Dr. Pease. What comes next after a piece of work like this? I mean, that last slide is pretty powerful. How do you increase adoption or increase understanding of something that fundamental?
So it's very challenging. How do you change the practice of medicine? And it's very hard because death is something you can't undo. It's very hard to make the arguments that we are not giving patients an opportunity to declare themselves and whether or not they would go on to have a good, favorable functional outcome if we're withdrawing care very early, and maybe giving these patients more time would allow us to have our patients do better. People don't like to hear that if they're physicians, and it's very hard to show that these patients would actually do well. It's a very reasonable thing for people to come back and say, well, prove that the patient who died wouldn't have died. We can't undo death, and that's the fundamental problem. It's very analogous to in the United States. We unfortunately still use execution as a method of punishment of prisoners. And we know, just based on statistics, there are many people who are innocent who we have put to death in the United States, just based on the number of people who've been exonerated decades later. But you can't prove once someone has died people stop looking into why did they die, what about their crime, you lose many witnesses. DNA evidence is no longer as viable or valuable to be able to be used. We know that undoubtedly we've put people to death in the United States who are innocent. We don't have a single person who we've been able to prove that with. So it's kind of a similar phenomenon. I can't prove that the patient who died would have done well. I can just statistically say that almost certainly there are some people who would have done well had we not been as aggressively responding care.
Yeah, I have a question, if you can hear me.
Yes.
Oh, you can. Great. I'm Todd. Nice to meet you. It was a very excellent talk. I was really enjoyed it. I was going to ask a question about the CT scans, because one of the things, if you go back to your slide with the CT scans at the very beginning,
this one?
Yeah, that one. So you were using that, and one thing that kind of struck me that I didn't know is that for the same injury, the amount of actual bleeding can vary. I thought it would be a little more consistent, but I was wondering if you standardize these CT scans, because the placement of the scan itself, exactly where it is. You know how it changes. Like if you look at the first picture and the second picture,
these are examples.
It's a different level.
Sorry, these are example single slices.
Yeah.
Just to provide examples of what this looked like. So these brains all look different, but in reality, these are three-dimensional objects, and they're slices that are stacked one on top of the other.
Right.
Unfortunately, standardizing CT scans or imaging acquisition is a lofty goal in medicine.
Okay.
Because there are dozens and dozens of companies that produce CT scanners or MRI scanners. They all have their own little unique way of doing it. The image is actually acquired in slightly different approaches.
Right.
And
okay.
Even within institutions, within the same exact scanners, if you go from one institution to another with the same exact company, same exact scanner, the radiologist might decide, one institution might decide, hey, I actually want a slightly different way that we're going to acquire this image. I'm going to put in slightly different parameters.
Right.
There's some very valuable reasons about this. For example, when I was at Memorial Sloan Kettering, they had some very different imaging techniques than we have here at IU, because all of their patients had, who they're looking for MRIs of the brain, had brain cancer. You're looking for different things than at Indiana University, where we're trying to treat the whole spectrum of disease. We're trying to treat everybody and understand many different disease entities that don't have the same requirements or may have different requirements for imaging.
Very good. That really explained it well, because that's what I was going to bring up, is that if the slices are even slightly off that size of the hematoma, would look completely different. And
within CT scans, the slices are 5 millimeters thick. Radiologists aren't the one who actually put out where you're going to start scanning and stop scanning. You have an radiology technologist who's going to do that. And there are thousands of those across the United States and Europe. And a lot of them just want to get through their day. They're not going to make sure that we perfectly required scan.
Right.
Beautiful research when it gives the human being enough information to make the decision, because it's not that big of a deal if you change the gantry angle or the slice angle a little bit. For me, I can still understand what's going on, but it makes it a much, much more complex modeling task.
Right. So that's what I was going to say. In a perfect world in the future, we would be able to standardize the slices, and then say you can take other slices as well for other things you want to see. But if you standardize the slices, that would help. But then my second part of that was, is there a way to measure the volume, the overall volume of the hematoma? And then you could score that against the volume of the cranium. Because if you have a smaller cranium, that same amount of blood volume would be much larger in effect.
So that's where my Mackay challenge was. It was, can you segment out these lesions in the head? And once you've segmented out the lesions in the head, adding up the number of, pixels is, trivial, right? The problem is so hard. And neurotrauma in particular seem to be the most resistant. Segmenting technologies and techniques have gotten a lot better. In some diseases, they're very, very good. Within neurotrauma, they just aren't. It's just a much harder challenge of identifying lesions, yes, no, and these lesions are so heterogeneous compared to cancer,
Sure.
sclerosis, or these other diseases, that they look nothing alike. I mean, let me find one of my slides. I mean, just visually, look how different these images look. And they're just different. Whereas, you know, MS, anyone who takes care of MS will say, oh, these are heterogeneous lesions also, but they fall into a much smaller spectrum of heterogeneity.
Mm-hmm. Well, excellent. Thank you very much. I appreciate it.
I appreciate everyone coming.
Okay. Are there any other questions for Dr. Pease? Nope. Okay. Well, we're almost at time in any event. So, Dr. Pease, thank you so much for that presentation. That was incredibly informative, and I enjoyed it a lot. Thank you.